Welcome, everyone. My name is Candace Cousins-Hopkins, and I am the Associate Director of External Affairs here at St. John's Riverside Hospital. We are so glad that you can join us today for our webinar about causes and triggers of chronic migraine. After the presentation, we will open up the floor for everyone to send in their questions, and our speaker will address them as he can. I would first like to acknowledge our amazing team who helped put together these webinars. Our Assistant Vice President of External Affairs, Denise Mananas, our Community Liaison, Nancy Anabi, and our Media Production Manager, Jason Latore. I would also like to acknowledge our wonderful community partners, Sally Pinto, who is from the Yonkers neighborhood naturally occurring retirement community, which is under the umbrella of the Yonkers Office for the Aging and Westchester Jewish Community Services, and also Z Baird, who's with the Yonkers Public Library. And we have 3 locations, the Will, Riverfront, and Crestwood. Thank you so much for helping us spread the word about our webinars. We really appreciate your support. Now I am honored to introduce our guest speaker, Dr. Sandeep Gulati. Dr. Gulati completed his neurology residency training at Long Island Jewish Medical Center and a fellowship program in neuromuscular disease electrodiagnostic medicine at Montefiore Medical Center, the Albert Einstein College of Medicine. And Dr. Gulati is duly board certified by the American Academy of Neurology and Psychiatry, as well as the American Association of Neuromuscular and Electrodiagnostic Medicine. Dr. Gulati has gained vast experience in clinical neurology and has dedicated himself to his private practice in the Bronx and Westchester since 2007. And he treats patients in all realms of neurology, including nerve and spine disorders, headaches, multiple sclerosis, Parkinson's, dementia, and stroke. His expertise includes performing nerve studies, balance studies, lumbar punctures, and administering Botox for a variety of indications. He is very passionate about neurology and is fascinated by the brain, mind, and body connection, and he takes great strides in better understanding and listening to the patient. So Dr. Gulati, thank you so much for being with us. Welcome.
Wow, thank you, Candace. Appreciate that. First off, thank you, St. John's and the whole entire team over there put things like this together. It's a resource for our community and for our patients, and the more we can do as physicians in that regard, I think it's better. Knowledge is power, and again, putting these formats together is great. So thank you for inviting me, and I look forward to today's discussion.
Great. So I guess the obvious question to start with is, what is migraine?
Right. So, a lot of people, as a neurologist, we see headaches all the time. And the idea behind migraine is typically I'm going to explain to you the way doctors think about it, in which there's a clinical presentation of a migraine, which is a headache. And the headache is usually one-sided. 50% of the time it's one-sided. It can be associated with nausea, vomiting, sensitivity to lights and noises, and typically occurs in women more than men, and typically around like 20s to 40s. That's the highlight of the time that we see people with these kinds of headaches. So that's a clinical presentation of a migraine, but what's actually happening in your brain? And what's happening there is spasm of a blood vessel. It's a spasm of the blood vessel, which triggers a nerve called the trigeminal nerve, which causes a cascade of actually inflammatory chemicals or neurotransmitters to be released, and that causes a major headache. And when it's in that paradigm, in that format, we call that a migraine.
I think when you kind of explained what a migraine is, you did talk about how it happens. Like, what is the actual cause of, what are causes of migraines?
What causes migraines, there's usually some genetic factor at play in which it can be inherited from some family members. It doesn't mean just because one family member has a headache, you're going to get it. But yes, we do see a run in families. That's probably the first factor in this. And then there's triggers. There's dietary triggers. They could be lifestyle triggers. So dietary wise, alcohol is probably one of the most common ones. Red wine, those things can cause it. Certain cheeses, different kinds of, like, for example, MSG can be a factor in this too. So there's definitely food triggers that can make it happen, and there's maybe some actually some food things that can make it better, which we'll get to. But in general, foods can make it worse. There could be lifestyle triggers like stress and anxiety. That can contribute to this. Sleep is a huge one as well. So if you're not sleeping, sometimes you're not eating, these can be triggers and cause your headaches. But very importantly, they are just triggers. That means that they can make your headaches, they can precipitate your headache, but they're not the cause. So it's important to distinguish that you may have an inherent risk for having migraines regardless of having a trigger. But the triggers are some things we can work on, because if you make it better, then you can help your headaches without, with potentially without avoiding being on medicines.
Gotcha. Okay. Yeah, so I did not know that. So migraines are hereditary, essentially, and
there's a hereditary component, to be fair.
Okay.
So it does run in families. We see that, but it doesn't mean that a family member has to have it.
Okay. And I've heard that migraines can get better over time, with women, maybe they're going through menopause or, just later in life. Is that true for everyone? Is that, will they get better when you get older?
So the truth is, headaches with these migraines specifically usually get worse during your hormonally active years. So between 20s and 40s are more common that we see this, and we do usually see a prevalence in women more than men to get migraines. That being said, you can have children with headaches, children with migraines, and they can be starting in their teenage years. They can get worse in their 20s to 40s, as we just mentioned, and usually by 45 and later through menopause, as the hormones start changing, we usually see an improvement on these medicines. Improvement on these kinds of headaches, and then we can potentially adjust their medicines or their interventions based upon that, because headaches may get better with time. Correct.
And you mentioned children. Have you seen a lot of children have migraines, and how do you treat them? How do you know that it's something that you need to look into?
Yeah, so just to be fair, I am an adult neurologist, so I do see adults only, but enough experience tells me that children typically usually there's a family history. Mom or dad may have headaches, so that's one red flag in saying that these could be migraines. But children are different, in the sense that their bodies are different. So it should be evaluated with a pediatric neurologist, just to make sure there's nothing else going on. But for children, there could be other factors at play. Dietary factors could be more at play at that age. Stress, anxiety could be a factor at that age too. But importantly, if your child is having recurrent headaches, they should be evaluated by a doctor. First, you go to your internist, and then you can probably refer you to a pediatric neurologist who can better figure that situation out. But the medicines we use adults, we don't always use for children. So they usually should be a pediatric indication for these medicines. So they are treated differently, and that's important to know. And typically we want to avoid medicines for our children. So we want to look at other lifestyle issues that we can probably integrate before we jump to a medicine, which we typically do faster for an adult. The other point I want to bring up, Candice, is pregnancy. So people with migraines, or women who get migraines, usually get better when they're pregnant. So it's kind of counterintuitive, but through the hormone changes that occur at that age, in that situation, usually headaches get better with pregnancy. But once you deliver, there's another surge of hormones, which usually that's when we see the headaches come out again. So important to know, whenever we see patients who get major headaches when they're pregnant, we have to be thinking of other things, because it's not typical.
Very interesting with the pregnancy, because you were saying the hormones, it may increase when, hormones are a little bit more heightened. So that's interesting. I want to go back to the triggers. I know you went through a few, but can you just expand on some of those that may cause a migraine?
Sure. The ones that I think are very important, again, are food triggers, and everyone is different. Some people may be very sensitive to certain medicines. For example, caffeine can be both a trigger and a cure for migraines. Some people can, if they get very sensitive to coffee or a can of Coke, some people will use that as soon as they get a headache. They can just say, I take a Tylenol, a can of Coke, and I'm good. So it can be, everyone's body is different. We need to respect that. But importantly, so caffeine can be a factor in this. Certain alcohols can be factors in this. Red wine, beer can be a known trigger as well. Cheeses, MSG, in certain, for example, someone's gonna have a Chinese food. They said every time I have this food, it's a trigger. So there's definitely going to be food triggers that we should be aware of. There should be lifestyle issues like sleep. Some people, if they don't get their sleep that night, people who have certain work day shifts and they work at night, and that can be a trigger as well. And stress, which is, to me, when we talk about COVID and as being the biggest epidemic, to me, stress, how we handle stress, is probably one of the bigger epidemics, and that's a huge factor in headache management, and we should never ignore that piece in how headaches are managed.
Great. And then if you get chronic migraine, are they affecting your brain in any way? Are there changes that you can see?
So yes and no. So is it affecting your brain? In general, it is not affecting your brain. If you get a headache and you wake up, you go to bed, and you get up, and after a few hours, you should be good to go. So in that respect, it's not leaving any kind of brain damage. And I say that very, very roughly, that term, but it's not damaging your brain by having a migraine. But what we do see is changes on scans that can be shown when people have migraines. So if someone has a migraine, we can't prove it on a scan. Very importantly, number one. But number two is you can see what we say is white matter changes on the brain with people with migraines. Now, if people think of your brain as just say a balloon, the outside of the balloon would be your gray matter, which is a certain part of your cortex, and the inside of your brain is called the white matter. Now, people with migraines can develop changes in that white matter, that interior part of their brain. You can see some non-specific changes, but as I just said, they're non-specific, and it doesn't mean that just because you have those changes, those are migraines, because we can see them in people with blood pressure, diabetes, and other conditions as well. But they're not ominous, they're non-specific. We can see that they're not diagnostic, but your brain can change with people with migraines, but it doesn't leave any permanent damage. Though, Candace, the way I would also bridge this is migraines, for the most part, are benign. They can be debilitating, meaning that they can affect your life, but they're fairly benign in the sense that they're not going to cause any major significant effect on your health. But there's certain times that migraines can do that. Now, people, for example, if you're a smoker and you're on birth control and you have migraines, it increases your risk for stroke. So there is a connection there's a small connection, and this is not to be an alarmist, but there are connections between migraines and strokes that we need to be aware of, and it's not common. It does exist. And we have to make sure that we know we have to make sure that everything's in line, that this is just a classic migraine and not anything else. The one analogy I'll bring up is a couple of years ago, I think on SportsCenter, there was a sportscaster who was she was at a football game or a sports event, and during live camera, she had slurred speech right on a live camera, and people remember that. And it turns out slurred speech can be a mimicker of a stroke. So that was, rightfully so, it was scary. I think she had to go to the hospital, but they found out she just had a migraine. So migraines can present like strokes, particularly the first time it happens. And if it manifests in a way with these other neurological signs, then the first time it could be scary and needs to be worked up. but every recurrent time, it doesn't mean you have to do the same thing. And that's important, because if it has the same pattern, it doesn't mean you got to do the, you have to do the whole workup. The patient should be aware, their family should be aware, their job should be aware that this can happen, but it should be somewhat reassuring and not alarming.
Right, right. Okay, well, let's talk a little bit more about the treatments. I'm sure there are medications that you can use, and other treatments that you do not need medication for. I know when I was reading your bio, it talked about Botox and how you use that. I know some people that I know who have migraines, they were like, what's going to happen, if I use Botox, my face going to be frozen, the side effects. Could you talk a little bit about the treatments and specifically about Botox and how that's used?
Yeah. So, I like this question because I realize when I'm in my office and I see patients, there's such a variety of how people want to be treated, and I respect that completely. Some people do not want medicines. So then we'll talk about vitamins, and that'll be the first thing I'll mention. So depending on how bad your headaches are, the first thing I would say is, first of all, lifestyle and potentially a vitamin management. So lifestyle, again, stress. If you're going, God forbid, having a hard time with your boss and you're getting a major headache, sometimes you have to address that issue for what it is. And yes, it can be precipitating your headache, but I never take away the idea that how much stress can affect our health. So number one, look at that issue in your life. Then look at your triggers, right? Because if it is, just say it is, this can of, this particular beer, this one beer that triggers it, you should know that avoid the beer and just try to make life easier for yourself to understand why you're getting the headache. So look at your triggers, look at your stress, look at your sleep habits. Those are number one. Number two, if you feel like, hey, you know what, I get these headaches, they're not that bad. I talked to my neurologist, everything looks okay. So what can you do? You can use magnesium. Magnesium oxide, about 400 milligrams a day, can be helpful for people, prevention for migraines. The other ones that are on the market are butterbur root, which is called Pitidolax. That's another kind of vitamin that can be used. Riboflavin, feverfew. These are all other natural supplementations can be they can probably be getting online even. It's not requiring a prescription, that can be used. And some people would just want to be on that tier. Now, most time when patients come to the neurologist, it's beyond that point, but I always give them that option. Now, there's a couple of ways we think about migraine treatment. Number one is abortive treatment. Abortive meaning that you take a medicine when you knock out the headache, when you have a bad headache. Then there's something called preventive treatment. Preventive treatment is the idea that you want to be on something to prevent the headaches from coming on. So there's two different models for treating headaches. Now, from an abortive standpoint, the first thing you can take is Tylenol, Advil, anti-inflammatories such as that, which can be helpful. Excedrin, migraine, these are just classic over-the-counter medicines that can be taken, and they're safe. But if they take them too often, too many times, they have their own complications. They can irritate your stomach, etc. So those are simple things you can start off with. Then there's the triptans. The triptans have been around for years, and these work on serotonin. And the bottom line is they're very effective medicines. They've been around for a long time. These are like your Relpax, your Zomig, your Imitrex, sumatriptan. Those are a whole slew of medicines that can be used, and they've been around for a long time. Now, those medicines are helpful, but they can cause some side effects, which the big ones I always refer to are chest pressure. If you take them too much, you can get a vasospasm in your heart, so they can affect your heart, and you can get rebound headache if you take it too often. So yes, they're effective, but they have their limitations. Now, the coolest things that have come around are these CGRPs, these calcitonin gene-related peptide medicines that are more recently available. They're very popular. If anyone's watching TV these days, Whoopi Goldberg's on one, Serena Williams is on one. So they have their own endorsements. But why we like them is because they usually don't have those two things I mentioned with the triptans. They don't cause a rebound headache, and they don't typically have any issues with your heart, your cardiac issues. So They're available through your physician. Your neurologist should be able to give. There's a couple on the market. Ubrevely, Nurtec are the ones that come to mind. They're available, and they're abortive medicines. When you have a bad headache, they knock it out. Then there's preventive medicines. Now, preventive medicines can be tablets you take every day, or they can be once a month injectables, or they can be Botox. And I give everyone options again, because some people don't want to take, younger patients don't want to take a pill every day. They don't want to take a preventive pill every day. Some rather do a once a month injection. And those are CGRPs. And I say this because this has changed the environment. Our landscape for migraine management has changed considerably over the last couple of years. And these CGRPs, these monoclonal antibodies, essentially are once a month injectables, which have really changed. They've become very popular in neurology in administering, because it's a once a month injection and it pretty much reduces how often you get your headaches. But you do have your old school tablets. You can take, one tablet a day of other medicines like Topamax and blood pressure pills. Tablets typically in the past that you take every day are used for different reasons. For example, Topamax is used for blood pressure and seizures, and so people don't always like to take a tablet every day that potentially is not as specific for migraines like the other medicines I mentioned. The Botox is another really effective way to deal with people with bad migraines, and essentially the criteria is people have to have more than 15 headaches a month, typically, when we go the Botox route. Botox, people didn't understand why Botox worked, but the plastic surgeons figured this out like 15 years ago. When they were doing cosmetic work, they realized that their patients were getting better for migraines, and they didn't know why. So Allergan, AbbVie spent billions of dollars of research to try to figure out what was going on here. And essentially, when we give medicines, it's an inside to out model. We give something inside that helps your headaches, right? Botox works from the outside in. So what we're doing is Botox is a microtoxin, and what it does is it relaxes muscles. It prevents a certain chemical to be transmitted between the nerve and the muscle. As a result, you get certain level of weakness. So if you figure this is your forehead and the nerve is behind it, by giving Botox on the outside on your forehead, by relaxing certain muscles, the nerve endings behind it get less inflamed, and that reduces the amount of chemicals that are being released. So Botox in itself, it does require a little bit more, in the sense that you get 31 little tiny injections in your forehead, your temporal muscles over here, the back of your head, and your neck. They're tiny injections. They work well, but it takes like 5 to 7 minutes, and it's every 3 months. So the why Botox is one of our favorites to use is, number one, it's every 3 months, which people like. They don't have to get it all the time. Mm-hmm. There is some really nice cosmetic side effects I'll mention, and it's a cool perk. But it's important to understand that Botox requires a medical condition for this regimen. You have to meet criteria for it. You just can't get it just because you want it. You have to meet medical criteria for your headaches. You probably have to try other modalities as well. But that being said, it works really well. Something I tell my patients, probably 95 to 90% of my patients who go the Botox route they don't go back. They keep coming back because it's that effective. So it works well. And just for the idea of an outside to in model, you're giving the medicine on the outside. It doesn't really affect your inside. So it doesn't cause any sleepiness, doesn't affect your libido, doesn't affect your weight. So people enjoy and feel safe with that modality. And so that's just one other tool we have in this migraine management tool.
Are there side effects with the Botox?
So that's why I actually like Botox. The biggest side effect is the cosmetic effect. And mind you, the forehead is where you see the cosmetic effect. If it's in your hairline, you won't. In your neck, you won't. You just get some relief from your muscle tightness. So if I inject Botox for different reasons for different parts of the body, but we're not injecting your eye. We're not there. If it's not done properly, I guess there could be a cosmetic adverse effect. So you have to know where you're injecting it. You have to know your FDA points where you're going to inject it, and you have to stick to a patient's own cosmetic presentation, because you got to use your head to say, okay, if I give it over here, I don't want to make their eyebrow go up or things like that. So you need to go to someone who's licensed, who knows what they're doing. But that's probably the biggest issue with it. People love it though.
Yeah.
People love it, and it's gratifying for neurologists to see their patients get better. So we like that.
Good, great. So yeah, how do you know if you do have something more serious? You know, you hear stories, people have been having these headaches and then, you know, they have a brain tumor or something. How, is there indicators there, a certain amount? I know you mentioned 15 headaches, you know, would be excessive, why someone would need, you know, Botox or something like that. So how can you determine if you should, you know, be worried?
Yeah, that's a huge point, and that's something we always have to address with our patients. In general, we call these red flags. Does your headache have a red flag? Now, we like to see some family history, not always. We usually like to fit into the paradigm of the fact that it's, you know, there may be associated with nausea, vomiting, sensitivity to light, noises. People like to sleep it off. We want to see it to fit that pattern. But there are migraines that present with aura too. So aura is some other neurological deficit. It could be some visual issue. It could be weakness or numbness. There's hemiplegic migraine, so it means half your body goes weak. So the first time you have an aura, it usually requires a workup, because the aura is not always common, and we call these classical migraines, but they're associated with aura. So they should be worked up just to make sure that these are still migraines. So usually we get an MRI and maybe some blood vessel studies just to make sure there's nothing else going on. So, but every time the aura happens, again, the point here is to reduce the amount of dollars we're spending on just workup. You don't have to repeat the workup every time. Other red flags would be, you know, sometimes these headaches can happen during even certain exertion. Exertion could be during exercise, during sexual activity. You can see these headaches. So depending on the circumstance of what's happening and the pattern and the evolution of headaches is always important, and that should be something that the doctor should be aware of. If it's ever associated with other, you know, weakness or numbness, things like that, I think those are the red flags the doctor has that we should be aware of. And once you fit in, you know, once you're fitting into the general model, you should be fine, and we can say these are migraines. But if you do have things that just don't feel right, these are, you know, patients will tell me, doc, this is not my typical migraine. The patient usually says it, no, this is not my migraine. They know what their migraines are, and they know when they're different. So if we listen, that helps out too.
Gotcha. Yes, that's most important. Well, great. Those are all the questions that I have for you today. I don't know if you have anything you would like to end with before I open it up for the audience. I have not seen any questions come in, but if anyone has questions, please type them in the question answer bar, and Dr. Gulati can do his best to answer them. Dr. Gulati, if you have anything else you would like to add.
No, again, just I appreciate these conversations. It's really important that we get the word out about how headaches are managed and in general health, because sometimes you just need an informal format to understand what's going on. Because people who have debilitating headaches, if they are not reassured, they can almost feel like there's something really major going on in their brain. So this kind of just getting the word out, understanding what's going on in your head, can make people sleepier better. They can give them less stress. So part of it is dealing with migraines, but part of them is reassuring patients that, hey, we know what's going on. We can deal with this. I've had patients who haven't seen a doctor in like 20, 30 years for these things. Know that there are treatments, there are things we can do for it. You don't have to live with headaches. You don't have to live with migraines. There's a lot of other types of headaches that are out there, but importantly, the landscape has changed. There's a lot of medicines out there, and with the right doctor, the right tools, you can be well on your way to living a healthy life.
Wonderful. Thank you. We actually did just receive a question from the audience. They're asking, what are your thoughts on keeping a headache log? What items would be helpful to track?
Yeah, so headache logs can be helpful because people's memory in the doctor's office is not always the best, because they're nervous and they just can't bring all their thoughts together for a few minutes while they're with the doc. So I do agree with headache logs. The bottom line is we really want to see how often you're getting your headaches and maybe what triggers they are. That's why I like using headache logs. So if, a lot of times you just don't, you just remember the major headaches, but you don't realize you're still getting more headaches than you think. So just take a little book or put it in your phone, say, I got a headache this day. You may realize you're getting more headaches than you thought, and you're able to, if you fulfill certain criteria now, because now you have more headaches than you thought, maybe you could get Botox, and maybe that would be relevant. And then you can also say what you're doing when you get the headache. Maybe someone went out for dinner and had that certain glass of Chianti that triggered their headache. So that may be helpful from a dietary lifestyle standpoint. What happened that day that could have potentially done it? And then you can always you can try to avoid those triggers too. So headache logs are helpful, no doubt.
So if anyone has any questions or would like to make an appointment with you, they can contact your office. It's at 970 North Broadway, which is across the street from the hospital. And the phone number is 914-410-3633. Dr. Gulati, again, thank you so much for joining us. We really appreciate it. The hospital has our virtual urgent care platform that you can call if you do not want to come into the hospital. That number is 914-964-4429. And then if you just have general questions or need a physician referral, you can call our phone number 914-964-4444. And for the physician referral, it's 914-964-4362. Again, Dr. Gulati, thank you so much for joining us. It was very insightful. We learned a lot. And we will be sharing this webinar on our Facebook pages and YouTube. And so please share them with your friends and family, rewatch them, and reach out to Dr. Gulati if you have any questions. Thank you so much.
Thank you, Candace. Appreciate the opportunity again.
Yes, thank you. Everyone,
we'll be in touch.
Have the rest of
Take care. Bye, guys.